Right, good morning, everybody. Today I'm going to be talking about acute meniscus injuries, what to repair versus what to resect. The objectives for today are as follows. First, we're going to discuss the epidemiology, the typical presentation following an acute meniscal injury. We'll continue to explore the role of the meniscus and its biomechanical function in the native knee. We'll summarize the Save the Meniscus initiative. Furthermore, we'll investigate different tear patterns and evaluate for their potential for repair. And then we will elaborate on certain patient-specific factors and their effects on outcomes pertaining to arthroscopic management of meniscal injuries. And last but not least, we'll highlight some of the future directions for improved outcomes following meniscal repair. So our first case today is an 18-year-old gentleman who presented to the office with pain and swelling in the right anterior knee. He sustained a non-contact injury while cutting during a football practice and immediately felt pain and noted a pop to the right lower extremity. He had difficulty ambulating after the incident. He notes a feeling of buckling in the interim and swelling that has mildly improved prior to his presentation today. He denies any numbness, tingling, or any other injuries. Of note, he has a past surgical history of a right femur antegrade intramedullary nail after a traumatic injury approximately 1 year prior. So his exam today reveals a mild effusion with lateral joint line tenderness to palpation. His overall range of motion is limited by pain. He has a positive McMurray's sign laterally and a negative Lockman's test. MRI was subsequently obtained based on his presentation. MRI revealed a lateral meniscal body tear. There was no evidence of any displaced fragments within the intercondylar notch. There appeared to be a radial component to this tear as well. So based on his presentation and his MRI findings, I just want to pause for a few seconds and think about what's the next steps. What would you do as the treating physician? And we'll explore this case after the presentation is concluded. Meanwhile, case two, different presentation than case one. This is a 29-year-old gentleman who presents for chronic right knee pain sustained after an unnamed traumatic event that occurred 5 years prior. He notes that he was told he had a medial meniscus tear 3 years prior after failing conservative management before that injury that occurred 5 years prior. Following the MRI, he was prescribed a course of physical therapy, noted mild to moderate improvement, but denies complete resolution of his symptoms. He presents today due to continued pain and intermittent mechanical symptoms of the knee, including locking, clicking, and catching. He denies any new interval traumatic injuries, numbness or tingling to the extremities. His past medical history is negative, and he presents today without an effusion. He has medial joint line tenderness, palpation. He's guarded with range of motion and McMurray testing, and he has a negative Lockman's exam. Similarly, MRI was obtained for this gentleman as well. See a large bucket handle medial meniscus tear with evidence of displacement into the intercondylar notch. Again, pause for a second and let's think about how we would approach this type of injury. Visit in just a few minutes. So overall, the mechanism can be relatively varied. There are many scenarios in which one can suffer a meniscal injury. The typical mechanism is described as a shearing or rotational moment about the knee during axial load. Oftentimes, this is described during an activity such as squatting or kneeling, i.e. in settings of closed kinetic chain flexion. Injuries may be atraumatic and or secondary to cumulative microtrauma. Ever so in the middle-aged or elderly population, acute injuries are often encountered during a sporting event, such as basketball or soccer, or as activities that require jumping and or pivoting, plus periods of rapid D and acceleration are frequently associated with their presentation. They'll be back. The history and physical exam are variable for patients presenting with meniscal injury. Joint line tenderness is common, although not a highly specific finding. Some may present with an effusion, although this is not a sensitive marker for the presence of a meniscus tear. Mechanical symptoms such as locking, clicking, catching, or inability to extend the knee may be present as well. Specialized maneuvers have been described, although their sensitivity and specificity are variable throughout the literature, as well as operator dependent. The Thessaly test, in which the patient stands on one leg, squats down to 20 degrees of flexion, and internally and externally rotates the knee through active adduction and abduction of the hip, is 75% sensitive and 87% specific. You also have your McMurray's, as well as your Apley's compression test, which a prone patient's knee is passively flexed to 90 degrees and then externally and internally rotated with axial compressive force. This test is pretty poorly sensitive, less than 20%, but is up to 80 to 90% specific. Meanwhile, a full ligamentous exam is often performed in the office setting, as meniscal injuries are often not found in isolation. For example, acute ACL tears are associated with approximately 50% risk of concomitant meniscal injury, and this number is even higher in those presenting with a chronic ACL tear. So in terms of our imaging, preliminary x-rays do have a role. They may be used to determine any concomitant bony pathology, including to rule out fracture or any loose bodies within the joint, as well as an overall assessment on the degree of arthritis and alignment, which can have an effect on the treatment plan. However, the gold standard imaging modalities determine the presence of a meniscal tear as MRI, noted to be greater than 90 to 95% sensitive and specific. Temporality for MRI imaging is patient-specific, depending on the aforementioned physical exam findings and the acuity of the injury. Diagnosis on MR includes contact of the intrameniscal signal with the superior or inferior, or with both surfaces of the meniscus, and secondly, distortion of the normal appearance of the meniscus. The anterior and posterior horns of the menisci and the body of the lateral meniscus have an isosceles triangle appearance, whereas the body of the medial meniscus has an equilateral triangle appearance and is shorter than the anterior horn. Normally, the superior and inferior surfaces of the menisci are equal length. A change from this configuration suggests the presence of a tear, albeit a rare MRI finding found in the medial compartment more so than the lateral compartment. The menisci can exhibit a flounce similar to a ruffled appearance of a ruffled piece of clothing, shown in the arthroscopic photo. So to take us through a historical perspective, the meniscus, meaning crescent-shaped body, is a diminutive of the Greek word men or moon. The first documented use of the word dates back to 615 BC, when ancient Greek poet Sappho used the term to describe a phase of the moon in his work titled The Fisherman's Tomb. From an anatomical standpoint, the meniscus was first alluded to by Hippocrates in his work on fractures in 400 BC, although he did not refer to it as its own distinct entity. Furthermore, unfortunately, advancements seemed to halt around the Middle Ages when anatomical dissections were largely forbidden. When we advance over 1,000 years, we return to the work of Renaissance physician Andreas Vesalius and his work of the structure of the human body. In here, he coined a new anatomic term, the semilunar cartilage. As we fast forward closer to modern day, we can show some important milestones. Sir Thomas Annandale was noted to perform both the first ever meniscal repair and meniscectomy in the late 1800s. In the early 1900s, Kattenstein publishes his results pertaining to meniscal repair and radical resection, noting that in his albeit small cohort of patients, the repair group overall seemed to fare better, while those who underwent radical meniscectomy often suffered from pain and varus deformity at late follow-up. In 1936, John King discussed the healing potential of peripheral meniscal tears in a series of experiments on dogs. In 1962, Masaki Watanabe performs the first arthroscopic partial believed to be the first partial meniscectomy. And as our understanding of the functional importance of the meniscus continued to evolve, Taper wrote on the long-term outcomes following meniscectomy, noting that the degree of degenerative changes as well as functional outcomes correlated with the amount of tissue that was resected. So as we approach modern day, we can take a look at the epidemiological data, which reveals that arthroscopy for meniscal-related pathology is one of the most frequent, if not the most frequent, for procedures worldwide, with approximately 1 million cases annually in the U.S. Of these cases, only 15% currently consist of repair, although this number is significantly higher than it was 10 to 20 years ago. The overall cost of the healthcare system is worth of $5 billion. There is an incidence rate of 66 per 100,000 person years for meniscal tears. Furthermore, several factors have been shown to increase the risk of the general population. Increasing age is associated with an increased likelihood of meniscus pathology, although these injuries in this age cohort are frequently degenerative in nature. Younger populations tend to have a higher rate of acute injuries, and those isolated to the lateral compartment. Other non-modifiable risk factors include sex, with a 4-to-1 male predominance, increasing BMI, and coronal malalignment. Meanwhile, athletic participation and physically demanding occupations, such as manual laborers or military personnel, have been shown to have higher probabilities of meniscal pathology. In terms of anatomy, the menisci are composed mainly of type 1 collagen with a higher predominance of type 2 collagen along the periphery. They are attached to the tibial plateau via the anterior and posterior roots and are stabilized by the medial collateral ligament, the transverse ligament, meniscotibial ligaments, and the varial meniscofemoral ligaments. The transverse intermeniscal ligament connects the anterior horns from each compartment. The roots function to anchor the meniscus posteriorly and aid in the conversion of axial loads into stresses, and ultimately prevent the extrusion of the menisci during joint loading. The meniscotibial ligaments, generally thicker and stiffer medially, anchors the meniscus to the tibial plateau. The medial meniscus also has attachments to the posterior oblique ligament and the posterior medial capsule. The medial meniscus is further reinforced through its denser meniscocapsular attachment that consolidates with a deep MCL. Laterally, the popliteus tendon partially disrupts the circumferential attachment of the meniscotibial portion, leading to a looser anchor point. Together, these properties allow the lateral meniscus to have increased translation and mobility relative to the more static medial meniscus, which has been shown to act as a secondary stabilizer of the knee. Initially believed to be a useless anatomical remnant, our understanding of the function and importance of the meniscus has grown dramatically. Meniscus plays a vital role in maintaining joint stability, providing nutrition and lubrication to the knee joint, and providing sensory feedback, as well as enabling shock absorption during gait, and most importantly, is its role in load transmission. So take a look at some of these in the next few slides. So in terms of joint stability, the superior surface of the meniscus is concave, enabling effective articulation between the tibial plateau and the convex femoral condyles. This allows the medial meniscus to act as a secondary stabilizer. This allows the medial meniscus to act as a secondary stabilizer of the knee joint. While in vitro biomechanical testing has shown little effect on the native knee with intact cruciates, an ACL deficient knee results in up to 200% more force, specifically on the posterior horn of the medial meniscus when a PA force is applied at 60 degrees of flexion. This is demonstrated in the graph up top using robotic force motion sensors on cadaveric knees at various degrees of flexion. Meanwhile, Markov et al. Described the degree of tibial translation following medial meniscectomy, while PA translation remains similar to those in the intact ACL knee. An ACL deficient knee demonstrated a 50% increase in translation in the absence of the medial meniscus. The chart below further highlights this effect, as well as the deleterious effects even partial meniscectomy can have on native biomechanics. Furthermore, although not as frequently demonstrated in the literature, the lateral meniscus may play a role in stability during combined valgus and rotary loads, such as those examined during the pivot shift. There is a complex interplay between the meniscus, synovial fluid, and overall joint nutrition, lubrication. An intact meniscus helps to reduce friction and ultimately extend the duration of lubrication during cyclic loading. Increased friction over time eventually leads to wear at the particular surface. This effect becomes more profound in the orthopedic knee as violation of the subchondral plate leads to fluid exchange and a profound depressurization at the joint level, thus increasing friction and subsequent degeneration. The schematic above provides a visual representation on the effect of partial and complete meniscectomy on contact area, peak force, as well as flow state in the normal versus arthritic knee. Mechanical receptors, to move on to sensory feedback, mechanoreceptors transduce mechanical information and convert them into electrical signals. There are fast and slower acting receptors present in the meniscus, mainly in the anterior and posterior horns. The former consists of sitting corpuscles, which mediate information related to the joint motion, while the latter comprises Ruffini endings and Golgi tendon organs, which mainly orient position. The tables above highlight a series of 46 patients who underwent ACL reconstruction with concomitant meniscal injury. Patients received a baseline proprioception score preoperatively upon presentation of their injury and subsequently underwent repeat testing at 12 months post-op. While proprioceptive scores uniformly improved across the board, partial meniscectomy was demonstrated to have a deleterious effect at 45, 60, and 75 degrees of flexion, while only 60-degree flexion angle showed a statistically significant difference for those undergoing repair. Meanwhile, those undergoing repair had improved functional scores as well, lending the authors to at least partially credit these findings secondary to the proprioceptive function of the menisci. Further research is definitely needed regarding this topic, as these injuries did not occur in isolation. Comparison between repair and meniscectomized patients without concomitant ACL injuries would be interesting and worthwhile. So overall, there's a paucity of literature pertaining to the shock absorption capacity of the meniscus. This is different than its load transmission function capacity. This small in vitro study utilized porcine samples demonstrated the potential effects on increasing the sequentially meniscectomized knee on force across the joint. A higher loss factor correlated with increased dampening potential and overall thus better shock absorption. The results of this study demonstrated a negative effect when additional meniscal tissue was removed under both conditions, including cyclic, low to moderate intensity, and impact loading states. The theory is that decreased shock absorption potential can lead to less force or force over time to reach a critical load that can ultimately lead to cartilage damage and wear. Most importantly, the meniscus plays a vital role in knee biomechanics, regulating load transmission during weight bearing. They function to convert axial forces into tensile circumferential forces, which are known as hoop stresses. 70% and 50% of the force during joint loading is transmitted through the medial and lateral menisci, respectively. However, a deficiency in these structures results in greater than 50% decrease in tibiofemoral contact area and a subsequent 100 to 200% increase in contact stress, thus harboring a higher force on the articular cartilage. The top figure is a rudimentary illustration demonstrating the principle of increased force per unit area as a result of anticipated hoop stresses, which can be seen as a consequence of a root tear or complete posterior horn radial tear. Furthermore, the bottom diagram portrays contact pressures at the tibial plateau at various flexion angles in the setting of an intact versus compromised menisci. Numerous publications have documented the peripheral rim being the most important element in facilitating these hoop stresses. But even as you can see in the diagram above, A 50% meniscectomized knee can see a modest but apparent increase in tibiofemoral contact force, thus promoting future articular cartilage wear. So in terms of blood supply, the meniscus is a relatively avascular structure. It is typically divided into three zones. This includes the red, which is highly vascular sections, the red-white, and the white-white. These indicate the amount of relative direct blood supply given to the given portion of the meniscus. Endoligamentous vessels, branches of the medial lateral middle genicular arteries, provide direct nourishment for approximately the peripheral 10 to 30% of the meniscus. The rest relies on synovial diffusion or mechanical pumping during joint loading. This is critical for understanding the healing potential for injuries to the structure, given the relatively avascular nature. To make matters more complex, the vascularity of the meniscus seems to diminish as we age. This can be a critical factor when determining both repair, especially in the middle-aged or older population. So given our, in modern day now, improved biomechanical understanding, we seem to understand the importance of the meniscus and have shifted our treatments and our plans for repair, essentially. As previously alluded to, even arthroscopic partial meniscectomy can have negative long-term effects on function and development of arthritis. Despite the strong short-term outcomes for arthroscopic partial meniscectomy, or APM, questionable long-term outcomes have shifted the paradigm more towards repair. This has led to the Save the Meniscus initiative, which has kind of come about over the past 10 to 15 years. On the next few slides, we will illustrate some of the literature that overall facilitated this shift in care. So this was an interesting paper published by Smith. They retrospectively reviewed a series of greater than 500 elite athletes that participated in the NFL Combine over a 5-year period. This was back in the, I believe their final year of inclusion was 2010 or 2011. This included greater than a third of all Combine participants during their 5-year period. Either through plain x-rays or MRI, they noted that athletes who underwent a previous meniscus procedure had a significantly higher chance of showing signs of arthritis in the ipsilateral knee. This number was 25% or higher, regardless of the department in which the procedure was performed. Overall, while these patients were mainly asymptomatic, it further highlights the future consequences that can help guide patient counseling prior to APM or prior to surgery in general. Unfortunately, there was a small repair cohort that consisted of about 4 or 5 patients, and it was ultimately too small to make comparisons or draw conclusions given the findings in this paper. On the other end of the spectrum, Romer performed a database case control analysis consisting of 355 knees with newly diagnosed arthritis, all older than 50 years of age. What they found was that a previous history of meniscectomy within the past year was associated with worsening radiographic findings consistent with arthritis. In the randomly selected matched control group, which were matched for age, sex, BMI, none of those patients in that cohort had a history of meniscal surgery during that period. Additionally, the help of MRI, the authors of patients who underwent partial meniscectomy demonstrated a 4.5 times higher rate of cartilage wear during the survey period. So from time to arthroscopic partial meniscectomy to their MRI findings, they were associated with these higher rates of cartilage wear determined based on MRI. As such, likely the majority, but not all of these injuries were degenerative meniscal tears in nature, given the age of this cohort. Overall, there have been a plethora of publications over the past decade cautioning surgeons against APM in the elderly population. However, there do remain select circumstances where this procedure is still an option, but obviously restraint must be exhibited. Furthermore, Lee performed a retrospective review on a series of 112 operations performed at a single institution. Patients aged anywhere from 17 to 70. So this essentially included all comers, and they were matched in both cohorts. Suitability for repair was determined intra-op at the discretion of the operating surgeon. Early follow-up revealed a modest benefit to partial meniscectomy in terms of functional scores, including our IK, DC, and Tegner scores demonstrated in the charts above. However, late follow-up revealed a statistically significant benefit in the repair cohort, specifically in terms of IK-DC scores. There was a benefit in terms of Tegner scores as well, although this was deemed to be close, but not ultimately statistically significant. Interestingly enough, not only were their functional scores higher than in the resection cohort, they demonstrated no significant change over the follow-up period, ultimately potentially highlighting the longevity of repair. So there's no free lunch. Meniscal repair does not come without complications. Paxton and his colleagues performed a systematic review comparing repair versus partial meniscectomy. They noted that the clinical outcome measures revealed a superior outcome for the repair cohort at follow-up of 4 to 10 years, as well as greater than 10 years. However, overall repair is associated with a significant higher reoperation rate, overall around 20%. This is pretty consistent with the majority of literature pertaining to meniscal repair, anywhere from 15 to 25%, depending on the particular paper that you look at. Additionally, this most frequently occurred during the 4 to 10 year time point and often results in subsequent partial meniscectomy, although repeat repair is performed occasionally. Interestingly, when we stratify based on concurrent ACL reconstruction, this procedure is shown to have a beneficial effect. The rates of reoperation were lower in those undergoing concomitant ACLR at the time of meniscal repair. This number was decreased by about 10%. This is ultimately believed to be multifactorial, potentially secondary to the healing factors after tibial femoral reaming, as well as potential inherent histopathologic changes in the meniscal tissue between the various cohorts. So our next steps, the treatment algorithm for acute meniscus injuries will encompass the majority of the remainder of this talk today. We will discuss patient-specific factors, tear patterns, and outcomes from the literature. We will glance over some other topics, such as transplantation, root repairs and tears, as well as arthroplasty, which all fall on the spectrum of meniscal disease, as well as degenerative tears, as they are outside the scope of our talk today. As such, non-operative management is useful for the initial treatment for acute knee trauma and as a first-line protocol, treatment in degenerative meniscal tears. Protected weight bearing, rest, ice, elevation are important early on in presentation. Certain tear patterns that are deemed stable and unlikely to progress may do well with definitive conservative management. These include, but are not limited to, small vertical longitudinal tears, which occur between the circumferential collagen fibers and thus do not disrupt the inherent stresses. Meanwhile, small horizontal cleavage tears often have a degenerative component and thus may become asymptomatic over time. Although they can develop into larger flap tears and mechanical symptoms may ensue, but can be valuable, at least in the initial presentation. So the choice to perform meniscal repair is dependent on preoperative tear pattern, patient-specific factors, as well as intraoperatively based on the surgeon's judgment. We will go through some data on the next several slides that may sway decision-making towards one treatment option versus another. So concomitant ACL insufficiency in the younger, less than 40 patient population is generally viewed as a contraindication to repair in the absence of reconstruction, secondary to the increased stress placed on the meniscus and a ligamentously unstable knee. Historical reports report up to a 30 to 40% failure rate, if not higher, in this cohort. Therefore, generally, it is not performed. On the other hand, meniscal repair in the setting of ACL reconstruction historically has been viewed as superior in terms of failure rates compared to an isolated procedure in a stable knee. Despite several meta-analyses demonstrating a modest 5 to 10% benefit, such as the presented previously, there have been a few small studies showing that this benefit might be overstated. Bogdanovich published a retrospective review in JBJS consisting of 83 patients. They reported similar outcomes for those undergoing concomitant ACL reconstruction, demonstrating by the KOS scores and IKDC values in the chart above. Additionally, there was no statistically significant difference in terms of failure rate between the cohorts over the designated 7-year follow-up period. Potentially new on-site techniques and biological augmentation may be responsible for improved success following isolated repair, although more literature is definitely needed. There are no large-scale studies demonstrating degree of coronal malalignment and failure rates for meniscal repair in the setting of simple patterns. Most of the data we have is extrapolated from the repair population. Moon et al. Demonstrated that a greater than 5 degrees of varus in the knee was associated with both decreased satisfaction and lower AKS functional scores. Additionally, outer bridge greater than 2 lesions were viewed as negative prognostic factors, as shown in the chart above. Other small-scale studies in the literature have demonstrated inverse correlation between success rate and malalignment above 5 degrees, specifically in the root repair population. As such, one should proceed with caution in this setting when planning for repair and consider additional procedures, including HTO, to correct any malalignment and improve the likelihood and longevity of success following repair. Historically, white zone meniscal injuries were not treated with repair given the lack of innate vascularity and poor healing rates demonstrated in vitro. Isolated repairs in this region have upwards of 35%, if not higher, failure rates, and this should be approached with caution. Majid et al. Retrospectively reviewed 122 patients who underwent meniscal repair. The overall failure rate was 17%. The tear patterns were stratified based on the zone of injury, albeit a small series of authors found a small but not statistically significant increase in failure rates for white zone injuries, noted to be 20%. Although repairs in this region can be successful, these results should be taken with caution. The authors used clinical symptoms to assess healing rates rather than second-look arthroscopy or MRI, which are more sensitive and specific, and had a short follow-up period of only 9 months. Frequently, repair failure can manifest at longer time intervals, around 3 to 4 years down the line, and up to 10 years, as demonstrated by the previously discussed research. So repair, when feasible, initially had taken hold in the younger population, secondary to some of the aforementioned reasons we spoke about earlier, including restoration of stresses, improved biomechanical function, and an overall prevention of osteoarthritis down the road. However, repair in patients over the age of 40 has been a current and ever-evolving debate. Initially, failure was thought to be inevitable, secondary to innate meniscal degeneration and chronicity of the tear encountered in this population. However, recent meta-analyses have started to change that narrative. Jabaji demonstrated excellent outcomes in patients greater than 40 following repair in their most up-to-date meta-analysis published in 2023. 13 studies and 360 patients were included. Patients with radiographic evidence of OA were either excluded in the reported publications or preferentially underwent partial meniscectomy. The overall failure rate was 15.6%, similar to previous publications in the literature for all comers. Interestingly, there were limited reports on patients known to be ACL deficient. In the combined ACL reconstruction plus repair cohort that was available, there was an overall failure rate of 8.5%. This was compared to 13% for which repair was performed in isolation in the setting of a ligamentously unstable or ACL deficient knee. The authors concluded that ACL deficiency should not be an absolute contraindication to meniscal repair in those above 40, although patients should understand that reconstruction can offer a better chance of survival. Limitations include the heterogeneity of the patient populations included, obviously different repair techniques, postoperative protocols, and judgment of healing, including second look arthroscopy, MRI, and clinically, as well as the duration of follow-up. As such, in the non-arthritic knee, repair may be a feasible option in those over the age of. To move forward, the elementary tear patterns for meniscal injuries are illustrated above. Once limited to longitudinal patterns, there is at least modest literature pertaining to repair and its success and role in each of these injuries. So in terms of radial tears, they are defined by the characteristic rent in the meniscus oriented perpendicular to its axis. They begin in the central white zone and extend into the periphery. They can propagate into other planes as well, as is the case with parrot's beak type tear highlighted above, thus potentially causing mechanical symptoms. Tears that extend 100% of the width of the meniscus essentially act as a complete meniscectomy of the given compartment, disrupting the innate hoop stresses and leading to accelerated wear and arthritis. Tachibana did a biomechanical review demonstrating the effects of varying percentage of radial tears on force concentration and torque in the lateral compartment. The results were negligible for radial tears up to 66% of width. However, complete tears produced a profound decrease in meniscal force, as well as an increase in valgus medial shift of the tibia, thus highlighting a failure of load dissipation under axial compressive loads. Furthermore, even for smaller tears that fail conservative management, partial meniscectomy might not be the best option. Goyle and Chen in separate analysis demonstrated that repair can improve the meniscal interface and prevent tear propagation, while also mitigating the effects of increased tibiofemoral contact stresses that may result after partial meniscectomy. Furthermore, Millerone published a recent meta-analysis on specifically radial tears in a young population. 241 patients were included, ages 23 to 37. 2/3 of the patients were male, and there were relatively even distribution between lateral and medial meniscal injuries. Uniformly, all studies reported improvements in functional outcomes and quality of life during a mean follow-up period of 3 years. 6 individual studies used second look arthroscopy or repeat MRI as shown above to demonstrate healing rates. The rates of failure during the secondary procedures was no higher than 13% during the follow-up interval. Inherent to the nature of the study, limitations include the heterogeneous patient population and an overall lack of stratification based on concomitant procedures performed, such as ACL construction. As such, recent reports have demonstrated impressive outcomes pertaining to radial tears, which were previously frequently resected. Overall, there is no consensus on when to fix these injuries, although many authors use a threshold of 2/3 or greater meniscal width involvement, along with an intraoperative assessment of the degeneration of the tear. And these are generally used by guidelines from what we can see in the literature. To move on to horizontal cleavage tears, they are overall a bit of a gray area when it comes to the meniscus. They are identified by a characteristic split in the inner free margin of the meniscal tissue extending into the intrameniscal substance, dividing the tissue into inferior and superior laminae. Pujol and his co-authors describe this pattern as neither traumatic nor strictly degenerative, at least in the younger population. Historically, they were treated by partial or subtotal meniscectomy due to poor tissue quality, frequent extension into the avascular zone, and or suture failure, secondary to varied shear stresses between the upper and lower leaflets. Biomechanical testing revealed limited resection of the leaflets, resulting in decreased tibiofemoral contact area and a corresponding greater than 50% increase in mean pressure across the pathologic compartment. This ultimately led to the advent of the single leaflet resection technique, which theorized that maintaining meniscal width while simply compromising height by removing the unstable leaflet restored native kinematics. Unfortunately, the biomechanical testing revealed nearly identical results to the double leaflet resection cohort. This study analyzed 30 knees aged 16 to 44 that underwent isolated repair of horizontal cleavage tears. Follow-up was greater than 3 years. The overall results were positive, with 85% of patients reporting satisfaction, mean IKDC and KOS scores approaching 90, and a low failure rate of approximately 15%. However, when we stratify by age, shown on the chart above, patients over the age of 30 sustained a steep decline associated with significantly lower outcome scores. Whether this is due to innate tissue quality or specific tear characteristics is unknown. However, the authors advise caution for repair in those above this age cutoff. Furthermore, the data regarding meniscal repair in the setting of horizontal cleavage tears is scarce, as we mentioned before. Occurs well for the meta-analysis. The 9 available studies that were included at the time of this publication. This included 98 patients with a median age of 23. The overall success rate was 78%, which is consistent with all tear types when it comes to repair. However, those over 35 tended to have inferior results. However, conclusions should be made with caution, as the definition for failure, at least based on their analysis, was deemed to be the presence of a second operation during varied follow-up periods, rather than our more sensitive and specific second look arthroscopy or MRI. Additionally, functional scores were not included for analysis within the study. Clearly, more literature is needed in order to determine the long-term benefits for repair in the setting of horizontal cleavage tears. Flap tears in and of themselves are not a distinct entity. They typically result from propagation secondary to longitudinal or radial tears, where a flap of meniscal tissue becomes displaced and trapped either on the notch or meniscal recess. They can be exquisitely painful and often cause mechanical symptoms. The authors from the study advocated for a multifaceted approach, where flaps were first reduced, as shown above, and then degenerative flap tissue was subsequently removed. The original tear component in this series, radial tears, were subsequently repaired. Ultimately, the salvageability of your meniscus following flap debridement will depend on the innate tear pattern and tissue quality, but in lesions that extend to the periphery, this may be a worthwhile approach. To move on to longitudinal tears, these are oriented between the circumferential fibers responsible for hoop stresses, thus having a smaller effect on tibiofemoral biomechanics. These tears are typically found in the periphery of the meniscus. Given their vascularized location, small tears below 10 millimeters can potentially heal spontaneously. However, larger tears become ever more symptomatic and further reduce native function. As such, these tears were historically considered the gold standard for repair, given their high healing potential within the red zone. Buzan and Associates analyzed 223 patients that underwent repair with an average age of 29 and an average follow-up period of nearly 5 years. They noted significant improvement in terms of functional scores shown above. Consistent with previous literature, they noted MRI confirmed failure was higher in those undergoing red-white versus red-red repair, which is to be expected, 33% versus 4%, respectively, and repairs performed outside the 8-week acute injury period, 27% versus 0% failure rate, where those performed at less than 8 weeks. Overall, there is literature supporting increased failure rates with longer tears in terms of length of injury. However, secondary to whether this is due to tissue quality or ease of repair is unknown. However, this paper reported no difference in terms of outcomes associated with a tear size above and below 25 millimeters of length. As such, it is necessary to counsel patients appropriately regarding such risks for repair failure and be prepared to do either procedure intraoperatively. Bucket handle tears are large longitudinal tears where in which a large fragment displaces into the intercondylar notch, causing pain and mechanical symptoms, and thus hindering native meniscal function. They are ultimately an evolution of large longitudinal tears. Ding retrospectively reviewed 1,359 patients, large cohort. This included all comers aged 12 to 65 who underwent repair for bucket handle injuries. They reported on factors influencing failure and the serious reoperation rate during the average 50-month follow-up period. The overall failure rate in this cohort was 20%. Concomitant ACL reconstruction and Asian race, unclear why, were deemed to be as protective factors. Interestingly, 12 to 18 age group had a 3 to 5 times odds ratio, which was significantly significant, of subsequent meniscectomy and any knee surgery during the follow-up period. Meanwhile, while those aged 18 to 30 had a 3 times higher odds of ipsilateral knee surgery of any kind during the follow-up period. This is likely secondary to the increased physical demands, whether athletically or occupation-based, encountered by those below 30. 10 plus year follow-up results would have been interesting to analyze to compare the different cohorts. So in terms of what's next, I shouldn't say final, but our next frontier is to find ways to reduce failure rates in meniscal repair, which consistently hover around 20% of the literature. Biological augmentation aims to improve cellular incorporation to the site, vascularization in the inner zones, matrix deposition, and inflammatory relief following such a procedure. Several methods are currently being investigated, including fibrin clot, mesenchymal stem cells, and PRP. Fibrin clot is repaired by collecting blood from the peripheral site, allowing it to heal. Clot is subsequently placed over the repair as a scaffold. It is believed that the chemotactic factors within the sample, similar to PDGF or platelet-derived growth factor, fibronectin, may stimulate local cell activity in the meniscus and attract synovial cells to favor the meniscal healing process. MSCs are typically derived from bone marrow, and their multipotency may promote healing in the right environment. Lastly, PRP requires centrifugation of a blood sample to utilize a plasma isolate contained with a high concentration of growth factors, including PDGF, TGF-beta, vascular endothelial growth factor, and IGF as well, theoretically promoting healing, at least into the knee joint follow repair. Overall, the literature is in its infancy with little data currently being reported. However, the meta-analysis above reported on all 3 of these techniques in patients. Data was small for the fibrin clot and the stem cell cohort, so conclusions were unable to be drawn. However, the limited evidence is promising for PRP. The forest plot above shows an overall statistically significant difference with an odds ratio of 0.31 favoring meniscal repair with PRP when compared to isolated repair alone. For rates of failure, given the heterogeneous nature of the studies included in a small patient population, clearly no definitive statements can be made at this time, but PRP remains a promising augmented setting of meniscal repair surgery. So to conclude our talk today, overall, there's a growing trend favoring repair over partial meniscectomy for meniscal injuries. Proper indications must be met, and patients should understand at this point the inherent risk for reoperation, approximately 5 times higher. Your reoperation rate after arthroscopic partial meniscectomy hovers over 30%. And overall, more data is needed regarding specific tear patterns, as well as our biological limitations to reduce this overall complication rate. So we will return to our cases that we presented previously. Show the MRI time. Does anybody in the audience want to comment on what they do? He was involved in NBC, I believe. Any of the residents want to comment? It's not. Yeah. Exactly the point we are trying to get to. At least for me, the radial component to the stair is difficult to appreciate on MRI. There's clearly some sort of pathology going on in the lateral meniscus. Um, However, repair versus resection is typically determined during the day of surgery. So ultimately, this patient underwent a repair. He was noted to have a complete radial tear extending to the capsular junction, shown in the image at the top left. This was a relatively clean tear without significant degeneration. An all-inside technique was used with the fast fix and the Soterix device. White zone tissue was debrided as this tissue quality was deemed to be unsuitable for a stitch, and you can see the final outcome. So overall, as Dr. Swan was alluding to, this patient is doing too well post-operatively, despite limitations. He's at approximately 2 months follow-up now. He's jogging, despite being told he shouldn't be jogging, and he's not complaining of any pain or mechanical symptoms at this time. So to be decided. The problem is you need to get so you need to repair the meniscal capsular interface, and you need to get sutures that bridge the tear gap as well. So that can be difficult. So the typical two techniques I've seen in terms of these radial tears are like a broad transtibial pull-out method where you drill tunnels into the tibia, tamp the meniscus down, bridge your meniscus across to reapproximate the tear edges, and then you have your rip stop technique where you usually first bridge your meniscal tissue, and then you reinforce with horizontal and vertical quote unquote rip stop sutures into the capsule to further fortify that repair. Moving up that. So moving on to case two. Here's his history. MRI time. Same sort of plan. He's a young guy. He has no past medical history. You can consider repair, but given the acuity or lack thereof and the inherent degeneration of the tissue, more likely than not need at least partial meniscectomy, which is what this patient underwent. The unstable bucketed fragment was noted to have been detached at least at one point. The fragment was bulbous. It was avascular and degenerative. The shaver, biter, and cautery were used to remove the fragment. And the rest of the tissue was shaved, debrided down to a stable rim. See that in the photo bottom right. Yep, 5 years. So it's again, it's that shared decision-making model and also intraoperative assessment. We know the ensuing compromise of the native kinematics and the function of your meniscus with getting rid of that tissue. However, depending on the size and the patient's ability to adhere with post-operative protocols, I would push more towards repair. But again, that's a complicated decision, and it really depends on how the tissue looks intraoperatively. Even if it's acute, you have to be able to repair it under proper tensioning or risk failure. So it's not going to work. So this is an evolution of a longitudinal tear, essentially. So the idea is to catch it early before it becomes this large bucket handle tear. This way, repair is more feasible, technically easier, and the outcomes are. I was not present for this case. No, it was already detached, at least partially, from the operator. In terms of red, 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 white, white, white. It looks red, white to me. Yeah. So if if it involved more of a red, red capsular junction, I proceed more towards repair. But there is a decrease in or increase in tibiofemoral contact stresses in white, white, even red, white tears, but less so than those encompassing a larger width. So those would push me away from repair. But again, it depends on how it looked if I was attempting to compare 4 or 5 years ago. Um, so in terms of leaving approximately 1/3 of innate meniscal tissue is described as being chondroprotective and maintaining some degree of stresses. Once you get above that, in terms of your section depth, once you get above 2/3 section, then you start to significantly increase your chondral wear and risk for compromising your biomechanics. So that looks to be about 1/3 to me, if not maybe a little bit more. So I think ultimately pretty well. Which is pretty experimental at this point, even if you have your laughing now. So we start with rasping the edges of meniscal tissue. That yeah, so you can do some drilling within your notch to help. Medial meniscus, just your patients report lower functional outcomes. Typically, you have increased contact force area when you lateral meniscal tissue compared to medial. Is he a candidate for second look arthroscopy, Dr. Swan? No. Thank you, everybody. Thank you, Dr. Gatt, Dr. Swan, and the rest of the sports faculty. These are my references. And any other questions I can answer for the crowd? Yeah. What do you think about so depends on their underlying degree of arthritis at baseline. It depends on their coronal alignment. Depends on their ability to, if you even mention repair, you have to have a patient. But as we've seen in the literature presented today, patients 40 to 50 years old shouldn't necessarily be excluded from that type of procedure. But I agree. What do you think of the mechanism? Oh, the mechanism tells me that that meniscus was going to fail eventually anyway. So the inherent tissue is degenerative in nature, as we kind of showed today. The innate blood supply, healing properties, density of structural material declines as you age. So that's why you typically see these degenerative or microtraumal / degenerative tears in the elderly population age, depending on your perspective. Thank you.